Hi students, welcome to today's session in oral pathology. I'm Dr. Gopi Krishnan discussing oral pathology with you. Okay, so in this video, we'll be discussing about OKC, odontogenic keratocyst. I think OKC is this familiar to you more than your name. Okay, because OKC you are learning from the UG classes. Okay, or there is no question paper without an OKC. Okay, so OKC we have to learn certain things for the entrance point of view. What they're gonna ask you in the entrance point of view, okay, rather than what you have learned. Okay, so OKC, there is a history for OKC. OKC was classified as a cyst in 1972 in WHO, World Health Organization 1972 classification. This was classified as a cyst, and later in WHO 1992. So these are the years where WHO has bought classifications. Okay, so again it was a cyst, and then later in 2005. Okay, WHO 2005 classification, what they did was they classified that they found that okay, this cyst is not actually behaving like a cyst, it is behaving like a tumor. So they renamed it as KCOT, it's keratocystic odontogenic tumor. So they called it as a tumor in 2005. Okay, so why they call it as a tumor? There are certain reasons. The main reason, please remember, the main reason is that they found that there is a mutation in this, and usually tumor has mutations, right? Tumor is caused by mutation. Cyst has no much relation with gene mutations. You may have seen that developmental anomalies as well as your tumors occur due to gene mutations. Okay, so in 2005 they found that there's a gene mutation which is seen in relation to this OKC. So it is not a cyst, it is a tumor, and you know the name of the gene because in the video of syndromes we have discussed a syndrome that is associated with OKC, that is basal cell Nevo syndrome, and we have discussed the gene mutation in that, that is PTCH1. PTCH1 gene is a gene which was seen in your basal cell Nevo syndrome, where you have a lot of OKCs, like multiple OKCs. Okay, if you are not remembering it, kindly go through the previous videos. Okay, kindly go to the video of syndromes and just have a quick revision. Okay, and that PTCH gene, the same gene, okay, same gene is found here. WHO 2005 they told that OKC has a mutation with this gene, so it is not a cyst, not but a tumor. But they couldn't stand, okay, that there was no evidence they could prove that this gene is really associated with OKC. Okay, so what they did that in the next classification, WHO 2017, they again put it as a cyst. Okay, now which is the classification we use now? It is WHO 2022. Here also it is a cyst. So this is the history of OKC. This is how OKC came. Okay, OKC came. Okay, so OKC has a very big history. Now let's see what is the features, what we have to learn in OKC. Now OKC has certain clinical features. Let's see certain clinical features of OKC. You know that OKC, it most of the OKCs comes in the posterior mandible region. Okay, nearly posterior mandible is the very favorite site for OKC. More than 50% of the cases, you can see the posterior mandible is having OKC. Then comes your posterior maxilla. Posterior maxilla. Okay, posterior maxilla comes next. Okay, that is the next site. That is nearly 20% of the cases we have posterior maxilla, and then comes your anterior maxilla. Anterior maxilla. Anterior maxilla is the next common site. 13% of the cases comes in the anterior maxilla, and least in the mandible. Okay, anterior mandible. Anterior mandible is least involved, 9% of the cases. Okay, so this is how the distribution of the cases, most commonly in the posterior mandible region. Why I am saying this? Because in the question you may get such things. Okay, 40-year-old male presented with a swelling in the posterior mandible region. So we should be very familiar with the presentation. I have told you the new pattern of question requires this, so every point is equally important. Okay, now what is next thing? Usually seen in the aged people. Okay, aged in the 40s 50s age, young adult and individuals, it is most common. Males are more common than females. Okay, males are more common, particularly in old age people. Okay, now this person will have swelling. Sometimes pain will be associated, pain or swelling. Pain or swelling will be seen. And if you take the radiograph, If you take the radiograph, what about the radiograph of a odontogenic keratocyst? Okay, so it is a cyst anyway. So we have a radiolucent lesion. Cyst is radiolucent. Okay, radiolucent lesions. The margins of this cyst, there's a peculiarity for this margins. Usually cysts are radiolucent with smooth margins. We call smooth margins, just like a dentigerous cyst had. But in OKC, we have a margin like this. Okay, so in OKC, it's a radiolucent lesion with a scalloped margin. Scalloped margin. So the margins are different here. Okay, the scalloped margins will be seen as a radiolucent lesion. It is a unilocular. It is a unilocular, means one locule is seen, unilocular radiolucent lesion with scalloped margins. Why there's a scalloped margin? Because this is not expanding equally in all direction. Okay, OKC has a tendency to expand. It has a tendency to expand. Most of the cysts expand due to pressure. So when you blow a balloon, it will expand equally in all directions, right? That happens in dentigerous cyst. OKC, what is the peculiarity is that the lining of the OKC has a particular power to proliferate its own. Okay, it has differential growth potential. Means every places, the different places, the lining will grow in a different rate. Okay, so what happens at some places, the lining will grow more, it will push more bone. Okay, at some places it will grow less. So it has a differential growth pattern. And what happens then, the lining will be scalloped. Okay, so that is what happened here. So I'll see the radiograph. I'll show you the radiograph here. Okay, so see the radiograph. In this radiograph, you can see that there is scalloping. See how it is scalloping. The margins are not that smooth. Here also you can see it is scalloping. That radiolucency, you can see that radiolucent lesion, that is scalloping margins. Okay, radiolucency with scalloping margins. And one interesting thing here is that OKC will cause more of the anteroposterior expansion. Means OKC has a tendency to grow from back to forward, posterior to anterior. Okay, OKC will go through the medullary space of the mandible. The mandible have two cortical plates, right? Cortical plates, the buccal and lingual cortical plate is there. Okay, and when a swelling comes, it will swell like this, right? To buccal and lingual swelling is there. But what happens in OKC will not waste time causing the buccal and lingual expansion. OKC is very genius. OKC knows that, okay, if I go through the central medullary cavity, I can expand more, because the central medullary cavity is very loose, right? Buccal and lingual cortical plates are very thick, right? So OKC is little genius that he will take the least resistant path. So the swelling will be going, the radiolucency will be going from posterior to anterior through the medullary cavity. So it will show a anteroposterior expansion. It can have an anteroposterior expansion more than a buccolingual expansion. Okay, the patient will not have an evident swelling outward, but the OKC may have gone till the anterior through the medullary cavity. So anteroposterior expansion will be more than the buccolingual expansion. This is the feature of OKC. So when they give you a radiograph, just see whether this applies or not. Okay, so this is one another thing. Now there are 4 different radiological types of OKC. Okay, so just like you had central, lateral and circumferential in your dentigerous cyst, you have 4 different types of OKCs here. So can you see here the first one here, the first one, you can see here, this one. Okay, so that is coming in a place where there is a tooth missing. So we have the first molar here, the third molar here, and the second molar is missing from there. Right, the second molar is missing. So the OKC came in a place where one tooth is missing. Okay, so one tooth but is completely converted to OKC. So in such cases, we say that this OKC has replaced the tooth but. So we say it is a replacemental. That is a replacemental type of OKC. Right, now if it comes in around an impacted tooth like this, number 2. Okay, if it is coming in an impacted tooth, we call it envelopmental. Means enveloping an impacted tooth. Envelopmental. Okay, number 2 is envelopmental here. Number 3, can you see the OKC came in the ramus region? So OKC came in the ramus region. OKC, from where this OKC is actually originating from the rest. Okay, your dental lamina rest. Okay, rest of serrae. Okay, rest of serrae is the main origin. Okay, it can originate, OKC can originate from your dental lamina. Okay, dental lamina or its remnants. What is the remnant of dental lamina? I'm not going into the basics of DADH. I think you are familiar with the remnants of dental lamina. There's the remnant of dental lamina present in the gingiva or in the bone is called your rest of serrae, right? Rest of serrae. So they can arise from that. Now you can see that rest of serrae is present in the tooth area where there is tooth. Okay, odontogenesis. Now in the ramus, okay, in the ramus region, there is no chance of getting a rest of serrae. But if an OKC develops in a ramus region where the tooth should not be usually present, means that OKC is arising in an extra site. Okay, in a site extra. Right? We say extraneous. Okay, extraneous. Extraneous type means it is occurring in the ramus. It is not in the alveolar ridge. It is not in the alveolar portion of the mandible. Okay, it is in the ramus region. So an OKC arising in a site far from where we should see the dental epithelium or the dental lamina or the rest of the array is called extraneous type. Okay, and number 4, you can see here the 4 has arisen in between the roots of two teeth. If you see an OKC in between the two roots of roots of a tooth, it is between or lateral to the root, collateral type means between the roots of two tooth. Okay, so these are the 4 types of OKCs. Okay, so one is a replacemental, if it is replacing a tooth bud. Okay, if it is originating in a impacted tooth, covering it, that is envelopmental. Third one is extraneous, if it is occurring in the ramus region, and if it is between the root, it is called collateral. So these are the 4 types of OKCs. Okay, now you have seen OKC, its clinical features, its different types, its radiographical feature, and its behavior of this anteroposterior expansion, scalloping borders, all that you have seen. So now we have a patient. Okay, now we have patient, we have seen the radiograph also. What next you are going to do? You are going to do a biopsy or a FNAC. Now we are going to assess it. We are going to diagnose it. Okay, how to diagnose? Now what I'm going to do? I'm going to put a needle and I'm going to take a fluid outside. Okay, I'm going to do FNAC. I did an FNAC. I took the fluid, I put a needle inside, I took the fluid outside, and what I am going to get here? What is the type of material in the lumen? So we are going to see the lumen. Lumen, what is there in the lumen of your your OKC? Okay, what we are getting, as soon as we put the needle and as soon as we take it out, we get thick cheesy fluid. Thick cheesy fluid. So we were getting straw colored fluid in in dentigerous cyst. Here we have thick cheesy fluid, right? We have thick cheesy fluid here. And what is this thick cheesy fluid? It is nothing but lot of keratin. It is lot of keratin. And if I do the protein assay, what will happen? What is a protein assay? I'm going to do the soluble protein assay. It will be less than 4.5 grams per 100 ml. It will be less than. It was more than 4.5 gram. It was more than 4.5 gram. Okay, not 0.45. It is more than 4.5 gram. It was more than 4.5 gram in dentigerous cyst, while it is less than 4.5 gram in your OKC. Okay, so you got it. So how you got the total protein content less than 4.5 gram, and that thick cheesy material is nothing but a lot of keratin. Okay, this much you got. Now what you're gonna see? You're going to see the lining. Oh yeah, here comes the lining. The lining is very, very important. Okay, so we have seen the lumen. Lumen contains thick cheesy fluid. Lining. Dentigerous cyst. Compare it with dentigerous cyst. Dentigerous cyst has just 2 to 3 cell lining. Right. Now see the lining here, how thick it is. And there is no retar edges here. It is very flat. No retar edges, I told you. Lining epithelium of cyst doesn't have any retar edges. Now this is actually 2 to 8 cell. Not 2 actually, it is 4 to 6 to 8 cells. 6 to 8 cell thick. What it is? Para-keratinized. Para-keratinized lining epithelium. Stratified epithelium. You can see the stratum basal. Here is a basal cell. Here is the basal cell, and here is the stratum corneum. stratum corneum, and the stratum corneum is para-keratinized. Okay, the basal cell here, there is stratum corneum that is para-keratinized. Para-keratinized means you can see the nuclear remnants in that. Okay, in orthokeratinized, what is the difference between ortho and para, that we will see when we discuss OOC, orthokeratinized odontogenic cyst. Now here in OKC, it is para-keratinized, 6 to cell layer thick, and you can see the basal cell layer. You can see the basal cell, the nucleus are all arranged in a line. Okay, the nucleus are arranged in a line. Okay, so we are seeing columnar cells, tall columnar cells in the basal layer. Okay, basal layer, and we have seen that the nucleus is palisaded. Palisaded, what do you mean by palisaded? Palisaded, the meaning of palisading is all are arranged in a same line. Okay, palisading, the meaning, you should know the meaning of every pathological terms. Palisaded means the nucleus are arranged in a same straight line. So you're seeing that the basal cell is tall columnar with the nucleus arranged in a straight line. We call the term, it is called a tombstone appearance. Tombstone, it's just like a tombstone. You may see in the tombstone in the graveyards, right, above the head of the dead body, or where the dead body is cremated, or in the underground. Okay, where the dead body is covered by the sand and one stone is kept over it, right, so that this guy doesn't come up. Okay, so that is tombstone. Okay, tombstone, we are making sure that this guy will not come up. We are keeping a stone extra so that he will not come again. Okay, the tombstone appearance, or we can say picket fence appearance. Picket fence appearance means picket fence is looking like this. Okay, just that appearance, picket fence appearance, tombstone appearance. Okay, that is seen in the basal layer. So this is the feature of your lining of OKC. You have 6 to cell layer thick, para-keratin. Okay, basal layer having tombstone appearance or picket fence appearance, and this there will be surface corrugation. You see the surface is corrugated. There is surface corrugation, means surface is not smooth, flat. It is wavy like this, right? The surface is corrugated, and this lining is very fragile. It can easily detach from the your underlying capsule. It can easily detach. Okay, so this is the feature of the lining of your OKC. Now I hope the lining you understood. Now coming to capsule, if you see the capsule, what is the feature of capsule here? The capsule of OKC contains certain things. The capsule of OKC has one interesting feature. They have daughter cyst. Daughter cyst means they have small islands of your odontogenic epithelium, or this lining epithelium. Okay, they have small islands of lining epithelium. The epithelium which is forming this cyst, the islands will be small islands will be present in the capsule. Okay, and this islands will cause a problem. If the OKC is not completely removed, what happens? These islands will be present there and they will form OKC again. Okay, so that will cause recurrence. Recurrence is, what do you mean by recurrence? Recurrence means coming again and again. Okay, recurring means once there's an OKC, you are removing it, again that OKC is happening, you are removing it. Okay, that is recurrence. So this is happening because of this, mainly because of this daughter cyst. Okay, so this is the feature. You have lumen with keratin. Okay, and lining so and so lining, and the capsule. So you know the histology of OKC right now. Let's see what's other than that. There is a question regarding recurrence. There are questions in the NEET examination regarding recurrence. What is the reason for recurrence in OKC? Okay, what are the different reasons for recurrence in OKC? You know, OKC is very much recurrent. Now, what are the reason for it? Now, there are certain reasons for OKC's recurrence. The most important reason for recurrence is the intrinsic growth potential. The lining of the OKC has a potential to divide its own. Okay, make a new tumor its own. The first main reason is intrinsic growth potential. Okay, intrinsic growth potential means the lining epithelium of the OKC has the potential to make next OKC. Okay, it has a intrinsic growth potential. Okay, second one, it is the satellite cyst, presence of this satellite cyst. So that is next reason. Satellite cyst is or daughter cyst. Okay, daughter cyst is the next reason, and the third reason is the friable lining. Friable lining. So all these are reasons for recurrence. We know that In the knowledge of UG, at the time of UG, we have learned that these are all the reasons for the recurrence. Now, in the entrance exam, they ask you which is the most significant or most important reason for recurrence. So, and you will have all the three in the option. Okay, you will have option intrinsic growth potential, satellite cyst, fibril lining. Okay, so all this will be there. Which among this is the most common reason or most evident reason? That is intrinsic growth potential. That is the most common reason or the most important reason for the recurrence of OKC. If this is not in the option, if this is not in option, then we go for satellite cyst. It's the second best option. Okay. So these things you have to keep care when you are attending the NEET examination. Okay. So this is how question regarding the OKC. Now, how you treat this? How we can treat the OKC treatment? You can enucleate it, but simple enucleation is not significant. You have to do a bone curating, because you know that the margins are scalloped. When you try to remove this, some remnants of this OKC will be still present within the bone actually. So the margins are very scalloped. You cannot completely enucleate it, and the lining is very fragile. So there is high chance that the margins will be or the lining will be present in that area. So what you did, you curate that bone also. You curate and remove the little part of the bone also from that area to remove any possible daughter cyst or any possible remnants. Okay, and then you can give a chemical cauterization. You can use Carnoy solution. Okay, so the surgeon, what he do is that he will soak some tissue, gauze piece, and he will soak it in Carnoy solution, and he's packed that area so that if any remnants is there, it will get destroyed or lysed by this Carnoy solution. What is Carnoy solution? It's a combination of 60% ethanol, okay, 30% chloroform, chloroform, and 10% glacial acetic acid, and 1% ferric chloride. Okay, so this is a Carnoy solution. You can pack that area with a Carnoy solution. So this is about OKC. Okay, I hope this is clear to you. And there are certain questions which they have asked. The OKC can be in the older times, it was considered as para-keratinized and orthokeratinized. Okay, in old times, OKC was divided into para-keratinized and orthokeratinized. Okay, ortho and para. Now this is a new entity. Recent classification has considered as a new entity, that is OOC. It is a different one, that is orthokeratinized odontogenic cyst. Now, orthokeratinized odontogenic cyst has a orthokeratinized lining, while OKC has a para-keratinized lining. And OKC is the one associated with the syndromes. Okay, which syndrome is associated with OKC? Your basal cell nevus syndrome. So in one question paper, it was asked which type of OKC is associated with syndrome. The para-keratinized one. Okay, the para-keratinized one is associated with syndrome. The new entity orthokeratinized odontogenic cyst is different. Okay, OOC is now different. What is the difference between OOC and OKC? There was one question. Please remember, which strata of epithelium. Okay, you have stratum basale, you have stratum spinosum, stratum granulosum, stratum corneum, right? Which strata is more prominent in OOC but less prominent in OKC? Okay, you just remember the stratum granulosum. Okay, stratum granulosum is very prominent. Okay, very prominent in OOC, but it is less prominent in OKC. Okay, this is one other thing. Recurrence rate is less in OOC. In OOC, the recurrence rate is less. Means the recurrence rate of OKC is nearly 13%, while recurrence rate of OOC is 3 or 2%. Okay, that is very less, and this is not associated with syndrome. No syndrome association. Okay. These are all facts which has come in the question paper. Okay, so I'm giving you in a very concise nutshell. Okay, so that you don't waste time reading necessary, you can just see the video and you get a complete thing. Okay, they won't ask you beyond this. Beyond this, there is nothing to ask. Okay, so OKC and OOC we have seen. Okay, now there is one thing about recurrence and malignant potential. Okay, see which cyst has increased or high recurrence. Okay, and there is one question, which cyst has high malignant potential. Okay, so many of the students has made confusion in this. Many of the students has made this question wrong. Okay, so please remember, OKC has high recurrence. Okay, OKC has a high recurrence. OKC, the lining, the intrinsic potential of the lining, the satellite cyst, the friable lining will make it more recurring. Okay, but malignant potential is for your dentigerous cyst. I've told you, malignant potential is one cyst is converting to another tumor. OKC will not do that. OKC will come again and again and again. That is recurrence. So don't confuse recurrence with malignant potential. Okay, so read the question very carefully. They may have asked you which among the following has highest malignant potential. So you are seeing OKC. Oh yeah, OKC, that is a dangerous one. Okay, OKC, no. Okay, malignant potential versus recurrence. Okay, never miss it. Okay, these are certain silly concepts, but you make wrong decisions in this. Okay, so I hope it is very clear to you. We have completed OKC. We'll see the questions later. Okay, so see you in the next class with the next topic.